Assalamu alaikum. Hi everyone. Today we're talking about physiology of menstrual cycle. So the learning objectives for this time is to describe the phases of menstrual cycle and hormonal actions. And then we're going to look at the ovarian and uterine endometrium, cervix and vagina. And we're going to look at the correlation of ovarian and uterine events in a normal menstrual cycle. And I'm going to discuss the negative and positive feedback control, and we're going to look at how do we know that there is ovulation, so indicators of ovulation. And we're going to look at milk ejection during lactation and the hormonal changes in the reproductive organ changes in menopause. So what's a menstrual cycle? When you say cycle, it means it happens periodically. So it's a regular cyclical changes in the ovary, uterus, cervix, vagina, breast, and hormonal changes in the blood. So, and this is to prepare for fertilization, and finally after that, pregnancy. And what we see obviously is that the menstrual cycle has got menses, or call it menstruation. And because of its obvious feature of these menses, we usually denote menses as day one. So the first site, or the day you have your menses will be as day one. So this is the overview of the menstrual cycle. You can see that here we have the what are the hormones involved, and what are the glands involved, and the phases here. So let me just highlight it in different colors. So you have first the hormones involved is the FSH, LH, estrogen, progesterone. So these are the four primary hormones that we're going to um, discuss a lot of all these four hormones and how these four hormones regulate the menstrual cycle. And the glands that are involved is the you can see here, pituitary, the ovary, the uterus, right? And when you look at the bottom part, we have the phases involved. So we have um, the numbers here denotes day. So I've mentioned in my previous slide, day one is always the first day of your menstruation, of your menses. So it's day one. And then as you go on, usually the menstrual cycle is about 28 days. But again, every person is different, so they may have slightly less or slightly more than 28 days. But in an average of 28 days menstrual cycle, you have the ovulation at day 14 right here. Okay. Right, so let's talk about a normal menstrual cycle. So I've talked about that, and on average, it's for 28 days, but it varies in every woman. And the days of the cycle are identified by number, starting with first day of menstruation as day one, right? The first day of menstruation is called is day one, and the average duration of menses is about 3 to 5 days. Sometimes it can go up to 7 or 14 days. What is the normal estimated blood loss? That is about 30 ml, and if you have more than 80 ml, then that is abnormal. Right, so the hormones involved in menstrual cycle. So we've mentioned this before, that there are four hormones primarily. So the first one is the FSH, right? So the FSH is being released from the anterior pituitary gland, and what it does is that it stimulates follicular development of the ovary, and it also plays a role in ovulation, and and that's it. So it's being released by the anterior pituitary gland, and FSH is one of the gonadotropin hormones, and FSH stands for follicle stimulating hormone. And then we have LH. LH stands for luteinizing hormone, and it is also released from the anterior pituitary gland. What it does is that it maintains the structure and secretory function of the corpus luteum, and it is also involved in ovulation, and we'll talk about that. And it with estrogen, right? So with estrogen, it helps in, it plays a role in ovulation. And then we have estrogen. So just now I've mentioned estrogen also plays a role in ovulations. Now, estrogen it has got two effects here on the menstrual cycle. It can impose positive feedback, it can impose negative feedback, and we'll talk about the both feedback from the estrogens and how it does that. Okay, but estrogen is being released, is being produced by the granulosa cells with the influence of FSH. And bear in mind that the process of producing estrogen is by converting androgen to estrogen. So androgen comes from the Theca cells. Theca cells produce androgens, and androgen will go to granulosa cells, and with the influence of FSH, granular cells will convert that and to estrogen, convert the androgen to estrogen, and that's how estrogen is produced. And then we have progesterone. Progesterone is being produced by the corpus luteum of the ovary, right? So but when corpus luteums regress or degenerate, it can also be produced by the placenta. Okay, so the changes in ovary during menstrual cycle. So we're going to look at first the ovarian cycle. So ovarian cycle, bear in mind when we talk about ovarian cycle, we're talking about the follicles and what's inside the follicle, which is the oocyte. Okay, so we're going to look at the functions of ovary first. Firstly, it has the primary function, which is gametogenic function, and this is for reproduction. It means to reproduce, and what's involved is that it's a process, the process called oogenesis, to produce gametes, and gametes are cells that are important for reproduction. And gametes are being produced or being released. The oocyte in particular, for the female, is the oocyte. So oocyte is being released cyclically, so through a process we call as ovulation, right? So the second function here is the endocrine function. Endocrine means hormone, so production of hormones, and ovary release estrogen and progesterone. And I've talked about the estrogen and progesterone pathway, synthesis pathway, in my lecture on sex hormones, so you can go through that if you haven't seen that lecture video yet. Okay, and there are other hormones too, like relaxin and inhibin, and we'll talk about the function of all these hormones later on. Right now, the in relation to the ovarian cycle, so the ovary is involved in follicular phase, and the follicular phase is where the follicles grow. For the follicles grow from primordial follicles to mature follicles. We call it Graafian follicles, and this follicular phase lasts up till before ovulation. So this is called pre-ovulatory phase because it's before ovulation. And then we have the luteal phase, which is after ovulation, so it's post-ovulatory phase, right? So the diagram down here is to show you what I've explained before. Just now I've mentioned that the estrogen is being produced by granulosa cells, but the androgen is being produced by the Theca cells, and these are the hormones that are involved. It influences all these cells to produce the androgens and the estrogen. And how do we make estrogen is from the conversion of androgen to estrogen, and this is using an enzyme we call it aromatase. So aromatase enzyme is involved in the conversion of androgen to estrogen, and this is under the influence of FSH. So the cells that are involved is the granulosa cells. Okay, so what we're seeing here is the structure of an ovary, right? So this is how it looks like, and the primordial follicles is what I mentioned before, is only stimulated to grow under the influence of FSH, the follicle stimulating hormone. So with the influence of that hormone FSH, these primordial follicles will start to grow to primary follicles, and then it grows again to secondary follicles, and finally it matures into a matured follicle, or we call it as Graafian follicles. As if you can see in this diagram, matured ovarian follicles is the one that has got the largest, or the largest antrum, and antrum is the fluid thingy that you see right here in this sac. So these are the fluids inside, so we call that antrum. So and then when ovulation occurs, it releases the ovum, and when the ovum is being released, actually is not the ovum is being released, it's the secondary oocyte, and we'll talk about that later, about why is the secondary oocyte is released. Anyway, during ovulation, secondary oocyte is being released, and what's left will develop into corpus luteum, which will finally regress and becomes corpus albicans, and finally, degenerates. Notice that you only see that there is only one Graafian follicle. So the idea is that although a few primordial follicles are being stimulated, and they grow up, and they grow bigger and bigger, and they mature, and each of these follicle will be will be giving off, will be releasing estrogens, and usually the follicles that has got the highest level of estrogen release, there are the dominant follicle, and this dominant follicle, because they release more estrogen, and and therefore they are more dominant, they are stronger, they are bigger, and they tend to have more receptors, so feedback is on to them. So because they are bigger, and they are stronger, and they're more dominant, and the rest of the follicles which are less less strong, they don't have that much receptors compared to these dominant follicles, and therefore they starts to regress. So finally you have only one dominant follicle that matures, and that dominant follicle will be the one that undergo ovulation. Alright, so this is another one on ovarian cycle, another diagram, but this time it's showing the oocyte, and similarly with the follicles, the oocytes are also growing inside the follicles. So starting with primary oocyte, it undergoes the first meiotic division and completes its, and then secondary oocyte will undergo the second meiotic division and stops at metaphase. So in this case, we say it stopped at metaphase 2 because it's metaphase of the second meiotic division. So it's metaphase 2. And then ovulation occurs, and ovulation is when the follicles release, the matured follicle, the Graafian follicle, releases the secondary oocyte, and the secondary oocytes will be out and pulled in from the ovary into the fallopian tube through the action of the fimbriae and the cilia of the fallopian tube. So it's pulling it in, right? And what's left becomes the corpus luteum, and we've talked about the degeneration of the corpus luteum right before this. And here in the right hand side, upper right hand side, I'm showing you the polycystic ovary, how it looks like. So you can see that there's dark spots covering all surrounding the ovary, these are actually follicles. These are actually follicles. And why is it's like that? So I've mentioned that with stimulation from FSH, you are stimulating a few primordial follicles to grow. In a case of a polycystic ovary patient, they with stimulation, they not only stimulate a few follicles, but actually a lot of follicles are being stimulated. So a lot of primordial follicles stimulated, you've got a lot of it, right? And a lot, when I say a lot, it can go up to 15 or more. So normally when I say a few primordial follicles are being stimulated, you can have at least 3 to 5, about that. So a polycystic ovary usually stimulates about 10 to 15 or more. So that's polycystic ovary. And when these follicles grow, these polycystic ovary follicles, I mean these primordial, a lot of them grows, and none of them become dominant. And therefore you can see almost all of the follicles are of the same size. On average they look like they have the same size, right? Because none of them is dominant. Since there's so many of them growing at one time, you have none of them being dominant, and because of that they appear to look like cysts, and we call them poly because there's so many of them. So polycystic ovary. So that's why it's called polycystic ovary uh, syndrome, right? Alright, so this is in detail of what happened in the follicular phase and in the luteal phase. Alright, so in follicular phase, we have primordial follicles beginning to develop in response to FSH and LH levels, but primarily FSH. So FSH and LH stimulate the theca and granulosa cells to produce estrogen, and we've talked about that previously, right? And how estrogen is being produced, and the surge of LH will induce ovulation, and this I will also explain in detail later on when we talk about ovulation. And then after ovulation, it's the luteal phase, so where the follicle will transform into corpus luteum. This is after the release of the secondary oocyte, and the corpus luteum will secrete large amount of progesterone and also estrogen. But if there's no fertilization, the corpus luteum will degenerate, usually in about 2 weeks. If, for example, there's fertilization, then corpus luteum will be maintained by HCG. This is secreted from the embryo. So if fertilization occurs, therefore there's embryo, and this embryo will produce HCG, and HCG maintains the corpus luteum from degenerating until there's placenta. So when there's placenta, then placenta takes over and takes over in the progesterone production. Alright, so let's talk about the hormonal control of ovarian function. We have here the hypothalamo-pituitary axis, hypothalamo-pituitary-ovary axis, the HPO axis. So this hypothalamo-pituitary-ovary axis talks about that the order of the control comes from first the hypothalamus through releasing of gonadotropin releasing hormone. This one will stimulates the release of LH and FSH from the anterior pituitary, and then this in turn will stimulate the ovary cells to produce the hormones. And let's look in detail at the arrows here. You can see that the FSH stimulates the granulosa cells, whereas the LH stimulates both theca cells and granulosa cells, right? And we've talked about the theca cells are producing the androgens, and the granulosa cells, with the androgen, it converts the androgen to estrogen. And estrogen, on the other hand, imposes negative feedback on the anterior pituitary and also on the hypothalamus from producing some more LH and FSH, right? Particularly it's LH. The estrogen has got this negative feedback, particularly primarily on the LH production, but it also has the the negative feedback on the hypothalamus. And then there's also inhibin. So inhibin is produced by the ovary, and this also impose a negative feedback on the anterior pituitary from producing FSH. Alright, so the feedback control of gonadotropin's secretion. So the key thing that you have to remember, that when you hit puberty, the release of GnRH uh, episodes occurs in episodes. So it means that release of GnRH and then stop releasing and then releasing and then stop releasing. So it's like episodes of hormone release. And this episode release of GnRH is important because only then it imposes a positive feedback to the secretion of FSH and LH. So previously there is no episode release of GnRH, which inhibits the production of FSH and LH. So that one occurs before you hit puberty. Right. What about the estrogen and progesterone? So we've talked about the estrogen production from the granulosa cells, right? And progesterone is being produced by the corpus luteum. And during follicular phase, FSH is elevated for follicular growth, and there's constant level of circulating estrogen, which exert negative feedback and negative feedback on the LH secretion. So LH secretion is, I would say, there is LH secretion, but not much, right? But before ovulation, all right, you have here high level of estrogen, and the sudden rise in the level of estrogen will exert positive feedback on the LH secretion, and this causes an sudden increase in LH secretion. We call that LH surge. So the burst of LH secretion, along with a slight increase in FSH, will cause ovulation, will lead to ovulation. And we'll talk about the process, the mechanism that is involved in ovulation later on. Right, so during luteal phase, LH triggers elevated progesterone and estrogen, right? So this is to signal the luteal phase. So because you have that LH surge, it also triggers progesterone and estrogen, especially primarily the progesterone, because that's the important hormone for the next phase. FSH and LH, FSH and LH level becomes low, which you can see in number 4, 5, and 6, and this is because of elevated level of estrogen. And if you remember the the HBO axis diagram, right, the estrogen impose negative feedback on them, and you also have the inhibin providing the negative feedback, and progesterone will also impose a negative feedback on it. If the ovum is not fertilized, corpus luteum regresses, what we call as luteolysis, and progesterone and estrogen levels will fall, and this leads to menstruation. So the drop in the hormones will lead to menstruation. Okay, so we've talked about estrogen previously, and that estrogen has got negative feedback and positive feedback on LH secretion, right? Then there's also this estrogen rise in the second half of the menstrual cycle, which is in the luteal phase and mid-luteal phase particularly, and this one is corresponding to its role in the preparation for pregnancy, if let's say there's pregnancy, right? So what it does is that it helps by stimulating receptors to be placed in the womb, in the uterus, in preparation for labor. And also another function is that estrogen, along with progesterone, helps in preparation of the breast. This is for breastfeeding, and we'll talk about that later on also in lactation process. And for progesterone, the levels remain low during the follicular phase, but after ovulation, there is an increase in progesterone, and this is because progesterone is being produced by the corpus luteum, and we know that corpus luteum only forms because of ovulation, because it has released its secondary oocyte. And so the function and the action of progesterone and estrogen, other than its main function that is not related to this menstrual cycle, I have this another lecture on it, which is on sex hormones. So I'm going to talk more about it there. So you can look for that, listen to the lecture for sex hormone as well. Right, so the endocrine control of ovarian function, and we've talked about FSH, that it is involved in the maturation of the follicles, the growth of the follicles from the primordial to the Graafian follicles. And then we talk about the FSH related to secretion of estrogen, because FSH is the one that influences the secretion of estrogen from the granulosa cells, and it is inhibited by inhibin, and activin is the one that enhances its secretion. So inhibin and activin opposes each other. And then we have combination of FSH and LH is for maturation of the follicle, and this is also involved in the combination of FSH and LH is also involved in ovulation, and we'll talk about that previously. And then we have the action of LH surge alone is the main cause for ovulation, right? And is also leading to the corpus luteum formation and the secretion of progesterone. Okay, so we're done with the ovarian cycle. Now let's focus on the uterine cycle. So uterine cycle is looking at the endometrium of the uterus. So uterus has got layers. Endometrium is the layers that is on the outermost, right? So if you look at day 1 to day 3 or 4 right here, let me just from here, right? So day 1 to 3 or 4 is the menses, is the menstruation day, right? And then from day 5 to day 13 you have the pre-ovulatory stage, and then you have day 14 ovulation, and then after that is the post-ovulatory phase. And basically in uterine cycle, the pre-ovulatory phase is actually the proliferative phase. Day 1 to 4 is the menstruation, and then pre-ovulatory stage is the proliferative phase, and then ovulation at day 14 and day 15. So post-ovulatory stage is actually the secretory phase of the uterine cycle. Okay, so the uterus, or particularly the endometrium, it undergoes changes. This is to prepare for in case there's fertilization and pregnancy, right? And two layers that I'm going to talk about to discuss on is, the first one is the functional layer or stratum functionalis, and the basal layer, the stratum basal. Now, the functional layer is the border that is the outermost, the borders the uterine lumen. And this is the one that is sloughed off during menstruation, and it contains glands, and this gland secretes mucus nutrients that are needed for the fetus to grow. And then you have basal layer. This one is being retained at menstruation and is not being sloughed off, and this is the layers that is important for regeneration of the functional layer after menstruation ends. And notice that I've highlighted straight and spiral arteries right down here at the bottom part, right? So straight arteries can be found in the basal layer, and you have more spiral arteries which are found in the functional layer. Okay, again, I'm introducing to you the phases that are involved in the uterine cycle. We have the proliferative phase, secretory phase, and the menstrual phase. Right, so usually day 1 start off with the menstrual phase, and then up to day 4, and then you have day 5, and before ovulation is the proliferative phase, and then day 14 is the ovulation, and then from day 15 and to the end of the menstrual cycle is the secretory phase. And if you look at the phases, and you look at the endometrium, look at the stratum basilis and look at the stratum functionalis, you can see that the stratum functionalis, I've mentioned before that it's sloughed off during menstruation. You can see that it becomes thinner and thinner, and it disappears at the end of the menses. And in the proliferative phase, day 5 to about day 13 is the proliferative phase, is the pre-ovulatory phase. You can see that there's an increase in the thickness of stratum functionalis. You can see it becomes thicker and thicker and thicker. And then you can see day 14 is the ovulation, and during ovulation you can see above there is a release of secondary oocyte. And then after that, day 15 up to the end of the menstrual cycle, which is day 28, you can see that the endometrial lining is really thick, and you can see especially the stratum functionalis, there's spiral arteries, and there's glands, and the glands are large and is really thick compared to the earlier part of the phase. So this is to prepare for in case there's implantation and there's pregnancy. Okay, so as a summary of the proliferative phase of normal menstrual cycle, right? So the duration, again, like I said, is from day 5 to about day 14, sometimes day 13. It varies between women. And then the changes in the endometrial glands, you have progressive lengthening of the endometrial glands, right? And the layer is like I said, is regeneration of the endometrial layer, right? It's building up, revascularization, reepithelialization from the basal layer. And then there is low prostaglandin level at this time in this proliferative phase, and the thickness is only about 1 to 3 to 4 millimeter. And its significant is that it restores, like I said, is a repair phase, is a regeneration from the basal layer, regeneration of the functional layer. And it regenerates because previously it is the menstruation, right? And so menstruation removes the functional layer, and now is building up a new one. So regeneration of a new functional layer. Right, so in the secretory phase of the menstrual cycle, the duration is from day 15 to day 28. Like I said, it occurs after ovulation, and you can see that the glands are coiled torches, and they secrete glycogen, and it's highly vascularized, has lots and lots of spiral arterioles, and it lengthened and coiled, right? So edematous stroma, and you have high level of prostaglandin, especially towards the end of the secretory phase. And the thickness is really thick. It's about 5 to 7 millimeter. And this is to prepare, like I said, for implantation if there is fertilization. So the menstruation is discharge of blood and endometrial debris from vagina. This is the hallmark of the menstrual cycle. And a hormonal support for endometrium is withdrawn, and then endometrium becomes thinner, and it leads to coiling of the spiral arteries. So we talk about the corpus luteum, and it doesn't last long if, for example, there's no fertilization and there's no embryo releasing HCG, which prevent the regression of the corpus luteum. Then the corpus luteum will regress, and that corpus luteum is the one that produces the progesterone and also estrogen in the secretory phase, right? And so with the corpus luteum regressing, you have the hormones being withdrawn, and this causes the coiling of the spiral arteries first, and then it undergoes vasospasm and degeneration of the spiral arteries. And this is due to the release of prostaglandins, and we've talked about prostaglandins being released, right, previously. And this, this is continuous, and then after that, it leads to when you have coiled of the spiral arteries. So you have all the nutrients and blood supply is being stopped, and this will lead to necrosis. And when necrosis, you have what tissue cell death, so tissue death, so the wall starts to fall off, and sloughing off of the wall is of the functional layer only. So the functional layer sloughs off because it undergoes necrosis and then death, and it comes out as tissue debris, right? And the blood and the tissue debris, and you have the prostaglandins and the fibrinolysins. And by then, the endometrium is infiltrated with leukocytes, and you have rhythmic contractions of the uterine myometrium. This is just due to the effect from the prostaglandins, and this is what we usually experience. A slight pain because of the menstrual cramps due to the contraction. And if you have excessively uterine contraction, then this is what we call as this dysmenorrhea. All right, so this is now we're talking about cervical changes in the menstrual cycle. So on cervical mucus, it's thinner and more alkaline. This is to promote survival and transport of sperm, and this is before ovulation, with influence of estrogen. The cervical mucus becomes thinner and more alkaline, and this is best for the sperm, and it helps the sperm to swim up and to meet up with the oocyte, right, the secondary oocyte. And then you have the mucus. It is really thin that when you stretch, if you use your finger like in a photo, you stretch it up, it will not cut off, right? So it's really elastic. And this is what you call a spin bucket, right? Spin bucket. And if you look under a microscope, you can see that if you spread it on a slide, you can see the shape is like fern-like pattern, right? Fern-like pattern. But after ovulation, now under the influence of progesterone, because progesterone is being produced mainly in the second half of the menstrual cycle, right? And we talked about that previously. And so the mucus become really thick, and it does not have that fern-like pattern anymore. And this thick mucus prevents the sperm from swimming up to the uterus, right? And swimming up the vagina, swimming up the cervix and vagina, right? And this is during the second half of the menstrual cycle under the effect of progesterone. Right. As for vagina, under the influence of estrogen, vaginal epithelium becomes cornified. And again, this can be identified if you look under if you look at the vaginal smear. And the cyclical changes take place in the breast as well. And I've told you that the breast is also affected in under the influence of estrogen, and estrogen causes proliferation of the mammary ducts. And this one, along with this progesterone, you can see that the progesterone also affects the breast in a way that it stimulates the growth of lobules and alveoli, right? So both estrogen and progesterone has an effect on the breast. So that's why when you have like breast swelling, tenderness, and pain during the 10 days preceding menstruation, this is due to the estrogen effects on the mammary ducts, right? So due to the distension and all that. And so progesterone is for the growth of lobules and alveoli, right? So what are the effects of lactation on menstrual cycle? So lactation is the breastfeeding period, right? So breastfeeding is lactation. Women who do not nurse their infants, they usually have their first menstrual period by the 6th week after delivery. And for those women who nurse regularly, means they breastfeed regularly, they have no period for about 25 to 30 weeks. So this is lactation amenorrhea. And then prolactin secretion is involved. This is for milk production, and you know that prolactin is one of the hormones secreted from the anterior pituitary gland. And prolactin, when prolactin is being released, it can inhibit GnRH and pituitary secretion of the gonadotropins. When you say gonadotropin, it refers to the FSH and LH, right? So it inhibits the action of the gonadotropins on the ovaries. So this is the milk ejection reflex. All right. So uh, it first start off with the trigger. So what triggers this reflex is the suckling of the baby. So as the baby suckles, it stimulates the sensory receptors, which is in the nipple, and this will stimulate the hypothalamus. Hypothalamus will release PRH. So PRH is prolactin releasing hormone. So prolactin releasing hormone will further stimulate the pituitary gland. So the anterior pituitary gland will release prolactin. So prolactin is involved, stimulates the milk production in the breast. And also along with it, posterior pituitary is also stimulated to produce oxytocin. So when oxytocin is released, oxytocin effect is for contraction of the myoepithelial cells in the breast. So what does it do is that when myoepithelial cells contract, it pushes milk out from the nipple, so you have ejection of milk. So bear in mind, prolactin is for milk production and oxytocin is for milk ejection. And also on top of that, I would like to inform you that other than suckling, it is also can be stimulated by hearing the baby cry. So if you hear the baby cry, you are already stimulated. The pathway has already started, right? It doesn't really has to start from the suckling process, but it has already started if from the very beginning when the baby started crying, right? So furthermore, it is further stimulated by the suckling stimulus. Okay, so the mechanism of ovulation, right? So let's talk about that now. You have mature follicles. We'll talk about the Graafian follicles, and when it mature, is ready to ovulate. So what does it do is that if you recall back that I've talked about the estrogen having that positive feedback, right? And then you have the LH surge, and together with it you have a slight increase, a rise in FSH as well, right? So LH surge will cause the release of progesterone, the start of the progesterone. So as progesterone is released, it will stimulate the release of enzymes. So these are proteolytic enzymes or collagenase. And the follicles will undergo hyperemia, and you have prostaglandin secretions. And the plasma, because of the follicular hyperemia, you have plasma transudation. Plasma starts flowing into the follicle, and the follicle starts to swell. At the same time, you have the enzyme attacking one area of the follicle wall, and one spot of the wall is weakened, and because of that weak area, that one particular area is weak, you have the follicle swells, and when it swells, if you have one spot is weak, it swells to the weak spot, and somehow it pushes to the weak area, right? So that weak area is what we call as the stigma. It protrudes out like nipple because of the swelling, because of the transudation of the plasma into the follicle. Right, because of this one happens, is continuous up till you have the follicle rupture, right? Also with the help of the enzyme weakening the wall, and so it ruptures. And then because of the rupture, you have the release of the secondary oocyte. Okay, so what are the indicators of ovulation? Okay, first and foremost, and the easiest one is to check body temperature. And this requires you to chart your body temperature every day, and usually at the same time of the day, usually in the morning. That's the best time. So when you wake up in the morning, chart your temperature immediately, and do that same time every day. You will notice that there is a slight increase in your body temperature, and that signals ovulation. That indicates that you have ovulated, right? Or you all can also look out for lower abdominal pain, but this is not really specific. Sometimes people don't have that. Some people, they have that. Or you can look at the serum level of progesterone or other hormone, for example, FSH and LH, because you went through the menstrual cycle with me previously. You know that which one is picking up, which one level increases right before ovulation. So use that, check that, and you can somehow predict your ovulation. Or you can use the evidence of progesterone effect on the endometrium. So endometrium, take a biopsy of the endometrium, right? Or you do a cervical smear, or you do vaginal smear based on what we have discussed earlier as well. Or you do a direct observation, and this requires you to do laparoscopy, like inserting inside like a tool with camera. You can really see the evidence of ovulation. So you can see like hemorrhagic spots, or you can see like the recently formed corpus luteum in the ovary, right? So this indicates that you have ovulated. Right, so the menstruation can also occur without ovulation, right? How does it do that, right? So, and this is usually occurring in the first few periods of your life if you just have gotten your period, which is your menarche. So menarche is your first period. So if you have just gotten your period, the first few times, sometimes it can go up to 1 year, sometimes more than 1 year, sometimes less than 1 year. In a few months, you'll have an ovulatory cycle, so cycle without ovulation. And right before menopause, you can have that too, right? Right before you end your how you say, your fertile period, so you can have that too. You can have cycle without ovulation. Right, so if there is no ovulation, then there's no corpus luteum formation and there's no progesterone actions on the endometrium. So what helps in the growth of the endometrium is only the estrogen, because you remember estrogen is also involved in the growth of the endometrium, right? And it goes on like that until it's thick enough to break down and become to slough off as menstruation. Usually it occurs less than 28 days, and the flow is variable and ranges from scanty to relatively profuse. And in mammals with a sexual cycle but without menstruation is what we call as estrous cycle. Right, so let's go through again the hormonal level on endometrium changes. Okay, first and foremost, day 1 to day 5 is the menses. And we've talked about that. What happens during the menses is the withdrawal of the hormones, right? Withdrawal of progesterone, withdrawal of estrogen, because there's no more corpus luteum. Corpus luteum has regressed, and that's it. So there's no more hormones, so the endometrium sloughs off. Right, it's slough off, and what's sloughing off is the functional layer of the endometrium. Right, and then at the end of the menses, you have estrogen level beginning to pick up, and this is because, why does it pick up? It's because remember, when there's progesterone, it inhibits the release of LH and FSH. Now that the progesterone has decreased, the level has decreased because of the, remember I said, withdrawal of the hormones, right? So now, because there's no more inhibition from the progesterone, now so the gonadotropins will be released now, right? So remember the HBO axis, right? So the hypothalamus starts to produce GnRH, gonadotropin releasing hormone, right? This will influence the release of LH and FSH from the anterior pituitary, okay? So this will have an effect on the ovary, and ovary will produce what hormone? The estrogen. Remember, LH and FSH work together to how they produce, again, recall back how they produce estrogen, yeah, from the granulosa cells, right? So you have a stable level of estrogen at first, increases slightly, right? So this will cause the negative feedback, remember? And then after that, you have a sudden rise in the estrogen, right? Really fast. And you can see the steep part of the estrogen rising, right? Rising rapidly, right? So this impose a positive feedback. Positive feedback on what? On the LH secretion. So now, because there is positive feedback, so now there's LH secretion being rapidly rising, right? Which we call as LH surge. So when we have that, you also have the increase of FSH, but not that high as LH, but FSH also rises. You can see the peak there in the graph, right? So with this will cause ovulation. And remember what happens in ovulation, right? You have the proteolytic enzymes taking place, weakening one area of the follicle. It's the Graafian follicle, if you can recall back. So one area is the stigma, right? So that weak area is protruding out because of the infiltration of, remember we talk about the follicle swelling, plasma infiltrating into the follicle. So it's somehow like pushing out and because the stigma is the weakened area, so it protrudes out like nipple, and finally it's, you know, it ruptures, releasing what? Releasing the secondary oocyte, right? Right, so when secondary oocyte is released, now what's left is forming corpus luteum, and corpus luteum starts to produce progesterone. So you can see the start of the rise of progesterone, right? And during ovulation, if you can recall, progesterone is also being released, right? So progesterone also helps in ovulation. But then again, you can see the rise is really rapid as the after ovulation. This is because of the corpus luteum, right? And you know, corpus luteum doesn't last long, so about 2 weeks, right? So corpus luteum, what maintains it is that if there is HCG, if let's say there's fertilization, then the embryo will produce HCG. So the HCG will maintain corpus luteum, so that corpus luteum will continue to produce progesterone and estrogen, right? So this will maintain the endometrial lining, the uterine lining, the endometrium, right? And but if there's no HCG, there's no fertilization, there's no HCG, then the corpus luteum regresses, degenerate, and therefore it no longer is producing the hormone. Then the hormone level drops, so progesterone and estrogen level drops. You can see that it goes down in the graph there, and the cycle began again. Because of the drop of the hormone progesterone and estrogen, you have the endometrial lining being sloughed off, and we've talked about how it is sloughed off, right, by undergoing necrosis and so on and so on, etc., etc., and it's sloughed off, right? So the cycle begins again. Right, so this is again another picture, another diagram. I show you the overall hormonal control of menstrual cycle, and this one includes the hypothalamus. You can see up there, right? And in A, the hypothalamus releasing the GnRH, and GnRH influence the release of the FSH and LH, right? So you have increase of this FSH first for follicle growth, right? And then you have the FSH and LH affecting the release of estrogen as well, right? Right, so estrogen also has an effect on the LH secretion, right? The negative and the positive feedback, right? And then finally acts on the ovulation. The ovulation is LH, FSH, progesterone. Okay, ovulation, and then you have after ovulation is progesterone and estrogen affecting the endometrium, right? So easy. Okay, again, let's go through the summary of events of the menstrual cycle. First and foremost, the follicular phase, or we call it proliferative phase, depending on what we're looking at, whether we're looking at the ovarian cycle or we're looking at the uterine cycle, and we'll talk about both of those just now. So day 1 to 14, right? So one primordial follicle will grow into Graafian follicle, the dominant one, right? And the rest will degenerate. And we have receptors for FSH and LH are upregulated in theca and granulosa cells of ovary, which stimulates estrogen. And the active estrogen will be the estradiol. And I've talked about the sex hormone more in my lecture called sex hormone. And the estrogen causes proliferation of endometrium, and there's negative feedback inhibition, there's also positive feedback inhibition, right? Okay, now during ovulation, number 2, during ovulation, it's usually at day 14 if your cycle is a 28-day cycle. And at the end of the follicular phase, a burst of estradiol will give a positive feedback on LH secretion, and we'll talk about LH surge already. And other than that, FSH as well, rise in FSH, and also progesterone, a little bit of progesterone, causing ovulation of the secondary oocyte. right? So estradiol level fall just after ovulation, but increase again during luteal phase. And we talk about that because estradiol are also involved in development of breast and also the uterus itself, right? The uterus, we're talking about the cervix and the vagina, right? Right, so and then you have number three, luteal phase or the secretory phase. So it's at day 14 till the end of the menstrual cycle, so day 28. And this is from the corpus luteum as its acid forms right after ovulation. It starts to secrete progesterone and estradiol. So you have high level of progesterone mainly, and this is to stimulate the endometrium to secrete. That's why it's called the secretory phase, right? So you secrete nutrients, secretes glycogen and all of that, right? Mucus, right? um, and increased vascularity, right? So more blood vessels. This is for pregnancy preparation. And there's low level of FSH and LH, and the rise in basal body temperature is due to the progesterone, and that's why I've mentioned during the indicators of ovulation, the easiest way is to chart your body temperature, because you will find that there's a slight increase right after ovulation, right, because of the rise of progesterone. Now, if there is no fertilization, like I said before, the withdrawal of the hormones, right? So because of the regression of corpus luteum, and this caused the sloughing off of the functional layer of the endometrium. Okay, now let's talk about the physiology of parturition. So it starts off with, the fetus. So as the fetus grow large enough that it stretches the opening, stretches the cervix, right? So this will send feedback, of positive feedback, and to produce more oxytocin. Now, oxytocin to produce, so when it first produces oxytocin, effect is to stimulate uterus to contract. Now, if you can recall back that oxytocin is also responsible for the contraction of the myoepithelial cells in the breast, right? So it's easy to remember because oxytocin is all about contraction. So contraction in the breast and also contraction in the uterus. So in the breast, contraction causing the milk to eject, and in the uterus, contraction causing the baby to to get out, to push the baby out, right? So as the baby is being pushed out, the baby's head starts to stretch some more, and this causing more and more positive feedback, and the cycle continues until finally the baby's out, right? And on the left side you can see I've put estrogen from the ovaries also induces oxytocin receptors on uterus, right? So I've mentioned this earlier before that it also affects the uterus, right? It affects the uterus in a way, induces the receptors. So having more receptors, the oxytocin produced from the pituitary will bind to the receptors and have that effect of the uterus to contract. So with advancing age, the ovaries become unresponsive to gonadotropins, and so their functions will decline. And because of that, you have a reduce in level of estrogen and progesterone, and there is no more negative feedback, and so you have continuous secretion of FSH from the interior pituitary gland. LH is moderately high, but you have a continuous level of those two hormones, right? And there will be loss of ovarian function and decline in the number of primordial follicles. Okay, so the menstrual abnormalities in clinical, I've introduced amenorrhea to you, and that simply means the absence of menstrual period. And there's primary and secondary amenorrhea depending on the situation. So if you never have menstrual period before, and you know, so if you have a problem, you're at the age or you're supposed to have period but you don't have period and you never had that before, so that's primary amenorrhea. But if you have had period before and then after something happened, something happened, and then you find that you don't have period for a long time, so that's a secondary amenorrhea, is because you already previously you had period before, so that's that. And then you have dysmenorrhea, it's a painful menstruation. You have hypomenorrhea, scanty menstruation. You have oligomenorrhea, reduced frequency of period. Menorrhagia, abnormally profuse flow during regular period. Metrorrhagia, bleeding from the uterus between period. And you have PMS, and all those irritability, bloating, edema. This is what we go through. I mean, if we're I'm talking about the girls, if you're a girl, then yes, I go through this and you went through this too, right? So the same thing. Okay, so if you, for example, you wanna know when is your fertility time is, when are you most fertile? Okay, for example, you're married and you want to plan, right? So what you need to know is you need to be charting down when you have your period. Now, even though you're not planning, I mean, you're still single, it's good to always chart your period, chart your menstrual cycle. At least, take note of the days that you have your period. For example, if you have your period today, put them in your calendar. Put it in your calendar that, okay, today I'm having my period, and until you finish your period, right? So at least you know that you have your menstrual cycle, whether or not it's regular, whether or not it's not, whether it's irregular. So you have an idea of what's happening inside your body, and it's good to know even before you are married, even before you want to start planning for a family. It's always good to start early. And so two things to know when using a calendar, and that is you have to chart again first day of your period. And I usually chart all the days of my period, right, from the first till the end of my period days. So I can at least look at how many days my period takes place, and look at whether it's in a normal range. And if it's exceeding the normal range, you at least you have an idea what's going on, right? So it's good to chart your period days. And by charting, you can, again, like I said, you know your duration of your menstrual cycle, and that's good. And you have an idea of if there's something wrong, if you're okay, right? And so how does your free ovulation calendar work is you enter your last period date and your cycle length, and that will calculate your future cycle for you. And this is if you have an app, or if you have an app in your phone, you can always download, and you can just key in your period days, right, and when your period ends. So it will help you calculate, and it will help you determine if you're okay or not okay, if you need to go and check what's happening inside. All right. And I think that's that. I think nowadays there are so many apps that can help you chart your menstrual cycle. And that is all for today. That is all for this time. Thank you for going through the video with me. And I'll see you again next time. Assalamualaikum and bye-bye.